go ahead and get started. Welcome everyone, good afternoon. And it's my pleasure to welcome you as the Associate Dean for Public Health. It's my pleasure to welcome you to our March rendition of Public Health Speaker Series. Before we get started, just a reminder, our guest will speak for about 40 or 45 minutes or so. We'll do question and answers at the end. If you have a question, you can put it in the chat. Hopefully we will have some students that want to come off of mute too to ask questions live. So we'll get to questions at the very end. And today I have the special honor of introducing a colleague who is going to introduce our speaker for the day. So Professor Lindsay Stark is a faculty member here at the Brown School. She's a social epidemiologist and internationally recognized expert on the protection and well-being of women and children in situations of extreme adversity. She partners with agencies such as UNICEF and the UN Refugee Agency and others to lead applied research and evaluation of interventions to reduce violence, abuse, and exploitation of women and children around the globe. Lindsay serves as our Associate Dean for Global Strategies at the Brown School, and she co-directs the Center on Violence and Injury Prevention, which is a co-sponsor of today's Public Health Speaker Series event. So with that, I'm going to turn it over to Dr. Stark, who is going to introduce our Public Health Speaker Series guest today.
Thank you so much, Angela. And I am delighted to have the privilege of introducing Dr. James Mercy. Jim is the director of the Division of Violence Prevention in CDC's National Center for Injury Prevention and Control. In this role, he provides leadership to innovative research and science-based programs to prevent violence and reduce its consequences. He received his master's and doctorate degrees in sociology from Emory and has worked to develop the public health approach to violence prevention for more than 35 years. Our good colleague, Matt Kruder, I think perfectly described Jim's contributions, citing Jim as a national treasure who is largely responsible for bringing gun violence research into public health. And I really couldn't agree more. Prior to his current appointment, Dr. Mercy oversaw global activities in the Division of Violence Prevention and implemented surveys on violence against children in developing countries as part of a global partnership called Together for Girls. With UNICEF, PEPFAR, WHO, and a number of us here at the Brown School actually have been involved in supporting some of those global surveys as well. As a researcher, Dr. Mercy has authored more than 250 publications that span the areas of child maltreatment, youth and intimate partner violence, homicide, suicide, and firearm-related injuries. We are truly delighted to have you here with us today, Jim. And with that, I will turn it over to you.
Thank you so much for that introduction, Lindsay. That's so kind of you. Let me pull up my slides, make sure they get up. And can you all see them?
Can.
Good.
And we see them in presenter mode again.
Okay, I'll switch that. And there we go.
Here we
Okay.
go.
Well, again, it's so wonderful to be here. And I want to say a couple things before I get into this, but the first thing I want to just acknowledge is that we're in the middle of an epidemic of violence in this country right now. And it has particularly hit cities, inner cities very hard across the country, but St. Louis has been one of the hardest hit. So you all live in a community that has been very hardly hit by this epidemic. At the same time, I want to also say that violence is endemic in the sense that it is so common in our culture around the world. About 50% of children in the United States are exposed to some form of violence each and every year. Around the world, similar levels of exposure, if not even greater in many countries. And then of course we have the extreme manifestations of violence as we're witnessing in the Ukraine right now in wars, and those conflicts and wars are also prevalent in many parts of the world as well. So violence is all around us, and I would bet that every one of us here has had some exposure to violence, either ourselves or in our families or in our communities. So it's a very important issue, and I don't think gets quite the attention that it deserves in terms of responding to it as a society and from a public health standpoint. I'm going to talk about several opportunities and challenges that we face in the field I think are very fundamental. One is the whole issue of scaling up violence prevention. Another is reducing the lethality of violence that's associated primarily with firearms. The third is recognizing and addressing the role of toxic stress. People have talked about adverse childhood experiences. It's a very important issue. And then I'm going to talk about some of the international opportunities to expand the work and build and learn from what's going on around the world. I think, to me, this is the most important challenge in the field of violence right now, is really taking the knowledge that we have and translating that into effective actions. It's not enough to know what's effective. What do we do when we have knowledge that we know is effective and translate it into something that can work and be applied and make a difference and reduce rates? At CDC, in the Division of Violence, we've developed these reports, which are essentially the compendiums of the best available evidence for action. We've developed them for child abuse, neglect, sexual violence, intimate partner violence, youth violence, and suicide. And what they do is try to pull together the evidence that we have that can be applied to reduce these problems. Now, one of the things that I've noted over the years is there's a myth that we don't know what to do to prevent violence. I think that's not true at all. We know over the past several decades, we've developed a lot of scientifically based evidence about what works to prevent violence. If you go to these compendiums on our website, they're really good one-stop shops for sort of reviewing that information and the nature of these problems. I think that's not to say we have perfect knowledge about how to prevent violence. There's a lot more we need to learn. But what I do note is that when we've seen outbreaks, infectious disease outbreaks, from Ebola to Zika to now COVID, nobody waited for perfect scientific evidence. Because they were urgent problems, we took actions based on the best available evidence. And that's why these reports I mentioned are really important, I think. But we know most about, if you think about the evidence sort of arrayed around a upstream versus downstream continuum. Downstream, those approaches to prevention that are most proximate, that try to change individual behavior or try to change relationships. And the more upstream approaches being those that really address the underlying social determinants driving violence. We know a lot more about those more proximate or downstream type of approaches than we do about the strategies to address social determinants such as poverty and structural racism. Big focus of ours, and I think is really important for the field, is begin to learn more about developing the evidence base around these underlying social determinants of violence. I want to show you an example of one of these reports, and this is the one dealing with child abuse and neglect, so you can get a sense of what's in them. They're first arranged around the different general strategies that can be used to prevent violence. In this case, there's one focus on strengthening economic supports for families, another on changing social norms to support parents, another focused on providing quality care and education early in life, another about enhancing parenting skills, and another one to intervene to lessen harms and prevent future risk. In other words, to intervene after a person has experienced violence. Within each of these strategies, then, there are specific approaches, and the documents review the evidence that supports those approaches, the evaluation research that supports these approaches. For strengthening economic supports, one type of specific policy strategies is earned income tax credits. We have increasing evidence these can be effective in reducing violence for example, child neglect. Another is about changing social norms, as I mentioned. Legislative approaches to reducing corporal punishment have been found to be effective, particularly in other countries, in Europe in particular. So an example of how we can learn from what's going on in other parts of the world. Providing quality care and education, for example, improving the quality of childcare, and reducing the use of violence in those settings. Enhancing parenting skills. Early childhood visitation is a classic example where nurses or other types of professionals go and visit homes of high-risk families after birth. It's been well documented to reduce child maltreatment. And then again, intervene to lessen harms. So for example, a child that experiences maltreatment, what type of interventions can mitigate the consequences, the mental health and physical consequences of that experience? There's evidence for that. So we have a lot of knowledge in this and other areas of violence. But the issue is, is how do we implement this knowledge? I'm sure many of you have seen the movie Field of Dreams. And it's about a guy in the Midwest, I think Iowa, who hears this voice telling him to build it and they will come. I think it was he will come in the movie. And in the middle of his cornfield, he builds a baseball diamond. And you have to watch the rest of the movie if you haven't seen it to find out what happens. But the dream in that movie was that if you build it, they will come. But in public health, the reality is that if you build it, they may not know. I had an opportunity at the end of the Obama administration to meet with the chief advisor to Obama on adolescence. And this person had no idea that we had a knowledge base on how to prevent youth violence. The person advising the president of the United States didn't really know that. We need, in implementation, the whole process of implementation, we need to do a better job of getting out the information we have, the knowledge we have, so that people know it. Because if they don't know it, they can't apply it. They won't apply it. If you build it, they may like the one they built better, even if it doesn't work. This is a common experience that people have in working with communities. And I'm not suggesting that even if we don't know that a community-based approach doesn't work, that it's not important. A lot of the evidence we have developed emerged from interventions, approaches developed in communities, but we need to evaluate them and see if they work. And we also need to try to convince communities to try to make use of the best evidence, what other people have applied in other communities and seems to work. Important part of the implementation process. If you build it, they will try to come, but the map you sent wasn't written in their language. This is the whole issue in implementation about adaptation. We have to be able to adapt the knowledge we have to the cultural context of the communities in which we're working. We can't expect that something that worked in Georgia is going to work in Missouri, or in St. Louis is going to work in Tampa Bay. I mean, we have to take into account the cultural context and economic context in which we're delivering these interventions. If you build it, they may want to come but can't afford admission. This has to do with the affordability of different interventions. Example of this is nurse home visitation. This is an extremely expensive type of intervention. It's also a lot of evidence for its effectiveness. But not all communities can just stand it up based on availability of resources. So how do we develop approaches and interventions that are affordable, that make sense? I also think we have a lot to learn from other countries around the world that by necessity develop approaches that are more reasonable in terms of their cost. How can we bring that knowledge to the United States? So this whole process of implementation, from planning to developing partnerships, The whole idea of implementing policy versus programs, there's different considerations there. What strategies, approaches should you use in the community? How do you adapt them and evaluate them? These are all important considerations and very important as we think about how we take the knowledge we have and scale it up and apply it. I think another element here is the political will. We need funding in order to support the expansion, the application of the knowledge we have in communities. And that hasn't quite happened yet, but we're moving in that direction. So the next opportunity and challenge I wanted to talk to you about is reducing the lethality of violence. And there's no question that when a gun is involved in either self-directed violence or suicidal behavior or interpersonal violence, that the chances of that event resulting in death are much greater. In 2020, there were over 45,000 firearm deaths in the United States. That's a big step up from 2019, by the way. 86% of those victims were male. About 54% are suicide. 1 out of every 2 suicides involve a firearm. 79% of homicides involve a firearm. About 121 people are injured every day from firearm injuries on average. And just to note, homicide has been the leading cause of death for young Black men for more than 4 decades in the United States. And second leading cause of death for Hispanic, and third leading cause of death for American Indian, Alaskan Native young men. So very important among youth in terms of its ranking as a cause of death. If you look at these 45,000 firearm deaths in 2020, you can see that, as I said, 54% are suicide, about 43% are homicide, and a very small percentage, 1.2%, are unintentional firearm deaths or accidental firearm deaths. Legal intervention, about 1.4%, and legal interventions are deaths that occur due to the operations of law enforcement. Now, I think this is an underestimate. Some people have documented it as an underestimate, but just to put it in perspective, in comparison to suicide and homicide, you can see this percentage here. Also important to know the health inequities that exist with respect to firearm-related deaths. In the light blue bars is the rates by race and ethnicity for suicide, and the darker blue is for homicide. You can see for suicide that the elevated rates are both among whites and American Indian, Alaskan Natives. And you can see the huge disparity that exists in firearm homicide for Blacks compared to other race ethnic groups. And really points to the need and the importance of taking on the issue of health equity in the context of violence. It's central to our work. We cannot prevent violence without addressing upstream issues like racism. We cannot. We have to take that on. This is the trends in firearm homicide versus non-firearm homicide since about 1981 until 2020, the latest year which we have full data. I want you to focus on the right-hand side of the chart. Between 2019, 2020, firearm homicide rates increased by 35% in the United States. 35%, and it's reached the highest level since the mid-1990s. That is also, we believe, the highest single increase in firearm death rates, firearm homicide rates, since the National Center for Health Statistics began collecting data on deaths. You can see that there were some bump ups before 2019, before the pandemic. So this may not be totally attributable to what happened during the pandemic. But this is a substantial increase. Also, the preliminary data for 2021 indicates that that these increases have continued into 2021. I want to mention some of the challenges, two challenges that I think are important in this work. One is the political challenge, I think should be obvious to everybody. Back in the late 1980s, early 90s, we were funding firearm research at CDC. And this is a long story, and I'll just hit the highlights, but we came under a lot of criticism. And this chart shows the kinds of criticisms we received from various elements in the field. And those criticisms eventually led to Congress almost eliminating the injury center at CDC that we're part of, the National Center for Injury Prevention and Control. There was a compromise reached, and what happened was Congress took away the money we were spending on firearm research and moved it into traumatic brain injury work. And for the last 25 years, until late 2019, we did very little work on firearms because of these events, politically motivated events that occurred in the early 1990s. Just in these past 2 years, we received funding from Congress to begin to take up this firearm research again. So it's a terribly important development and allows us to again get into developing science-based research that can lead to hopefully effective solutions. This language was put in our appropriations language in 1997 to sort of illustrate what Congress did. And it says that CDC may need to collect data on the incidence of gun-related violence, but the committee does not believe it is the role of CDC to advocate or promote policies to advance gun control. So that really sent a chill through the agency, and has just begun to thaw in these last 2 years. So the political challenges are real, and I think something we're going to have to figure out how to resolve. Are there areas where we can come together across this ideological divide? Are there, how do we move forward and make progress? How do we elevate the importance of science in helping to guide us forward? So that's a big challenge. Remember Newtown. This slide makes me sick to my stomach every time I see it. But I want to use it to illustrate a perceptual challenge that we have. And that is that the media, as you know, in looking at this events over the past decade or more, that great attention is given to the issue of firearm deaths, firearm homicides, when there are in the context of mass shootings. But these mass shootings constitute probably around 3 to 5% of all the homicides that occur in any given year. The reality is that every day in this country, on average, 23 young Black males die from firearm injuries, from firearm homicide. And yet that often gets missed or not focused on, or not remembered, or not looked at. And in essence, we have the equivalent of a mass shooting of young Black males on average, every single day in this country. You know, I ask you to consider, if homicide was the leading cause of death among young white males, would we be in the situation we are in today? Would it be different? I think we have to ask ourselves that question. And if it would be different, how would it be different? And what should we be doing now to prevent this travesty? The next challenge and opportunity I wanted to mention was recognizing and addressing the role of toxic stress. You know, when I first came to work in violence, violence was characterized within public health as an injury problem, a physical injury problem. That's why we were concerned about it. It caused physical injuries. what we've learned over the last several decades is it's much more than a problem of physical injury. What we know now is exposure to violence, particularly during critical periods of development, during childhood, and even up into young adulthood, when the brain is still developing, can have really fundamentally important effects on our development. And the mechanism through which they have these effects is what people have labeled toxic stress. That's sort of the causal mechanism that leads to changes in the brain, that leads to release of stress-related chemicals and hormones in the brain that can actually change its structure and change the way it works in fundamental ways. And what we've come to learn is that those changes in the brain can lead to changes in behavior, particularly risk behaviors, conditions that lead to a range of health and social outcomes, as well as cognitive development. There's also evidence that it can actually change DNA, change telomere length, change fundamental aspects of our bodies, gets under the skin in fundamental ways that actually can be passed on to future generations. So we're learning, there's a lot more to learn about all this, but the evidence is just really accumulating around what we're learning about this impacts of violence, not just violence, but other sort of adverse experiences that children have that can lead to toxic stress and changes in the brain. One of the areas of research that people have been engaging in is around adverse childhood experiences. And these are potentially traumatic experiences that occur in childhood and that can have lifelong impacts on health, as well as influencing violence and economic opportunities. On the right here, you can see the types of adverse experiences that have been traditionally used. There are different types of child abuse and neglect, as well as household challenges, including parental mental illness, divorce, parent-treated child witnessing intimate partner violence in their family, incarceration of a parent or relative, parental substance abuse. But these aren't all the adverse experiences that children can experience, right? Experiencing discrimination, experiencing racism, or experiencing discrimination due to sexual orientation, for example, can also be very traumatic. Experiencing bullying or peer violence, experiencing teen dating violence, homelessness, food insecurity. These things, witnessing violence in the community, are also potentially traumatic experiences. So what I'm going to show you, one of the things they do in this research is to develop an ACE score. And it's based on these types of adverse experiences on the right. And what they basically do is, through questionnaires, they ask people, how many have you experienced each one of this? And they add up the number of adverse experiences that they've experienced. And I'm going to show you slides that are organized in the same way in a minute about these experiences. I'll explain in just a second. But first thing to note, we did what's called a vital signs report a few years ago using data from the Behavioral Risk Factor Surveillance System. And we found that 1 in 6 adults experienced 4 or more types of ACEs during their childhood. This is a survey of adults. That these ACEs are associated with 5 of the top 10 leading causes of death. And you'll see that more clearly in a second. Just one outcome in looking at the preventable fractions is preventing ACEs could reduce the number of adults with depression by as much as 44% if you were able to somehow magically eliminate ACEs. So it's a pretty prevalent problem, very prevalent problem. And the real issue here is the accumulation of adversity. Let me begin to show you some of these data, and I'll go through it pretty quick, get the sense of it as I go through this. this is the ACE score and different types of risk factors for smoking or outcomes related to smoking. I notice there's a mistake here. This should not be the percentage of participants on the left. It's the adjusted odds ratio. I'm sorry about that. But look at this. The more ACEs that these respondents experienced, the more likely they were to initiate smoking at an early age. So those with 4 or more ACEs, adverse experiences as children, were much more likely to initiate smoking early than those with no ACEs. Current smoking, again, you see the same stepwise pattern, right? Those experience more ACEs are more likely to engage in current smoking. Chronic obstructive pulmonary disease, you see it's not quite as nice of an increase, but you still see this increase in the experience of that outcome that's associated with smoking. Now I'm going to go through slides that are very similar to this. Here's the same type of relationship with adult depression. You can see the more ACEs you experience, the more likely that respondents would experience depression as adults. Very serious mental illness. Here's the relationship between the ACE score and teen sexual behaviors. Again, that shouldn't say percent of participants, it's the adjusted odds ratio. But you can see that intercourse by age 15, teen pregnancy, and teen paternity all follow a similar pattern. Here you can see relationship between the ACE score and HIV risk. Again, ever injected drug use, you can see the increase with the increased number of ACEs. Having 50 or more intercourse partners, same pattern. Ever having an STD, same pattern. And here's something we did a few years ago in looking at life potential. We find the same pattern. We're talking about high school non-completion. A similar pattern when we talk about unemployment as an adult. A similar pattern when we talk about household poverty status as an adult. So not only are experience of adversity as a child related to a range of health outcomes and risk behaviors, but also these social determinants. Cardiovascular disease. Even we find relationships with a number of different types of chronic diseases. A few years ago, we did an analysis to try to estimate the preventable fraction associated with the range of health outcomes that was related to exposure to adverse childhood experiences. Again, we use data from the Behavioral Risk Factor Surveillance System. And what this means is that if you could magically eliminate all ACEs, what would be the likely impact on these outcomes in terms of their rate or level? You can see that as I mentioned earlier, for depression, result in a 44% decrease. For smoking, a 15% decrease. Current smoking, a 33% decrease. Unemployment, a 15% decrease. Now, it's unreasonable to think that we could eliminate all ACEs. But the point of this is that preventing these early exposures to violence and other types of adversity is strategic from a public health standpoint. Because if we can prevent them, if we can reduce them, we can impact not just physical injury, but a whole range of health outcomes. Really makes this work and the issue of violence fundamental, not just to the area of injury, but the whole, but public health across the board. Here's another way of expressing these cases. The 21 million fewer cases of depression if you could eliminate all ACEs, 1.9 million fewer cases of heart disease, 2.5 fewer cases of overweight or obesity. I want to end just talking about positive childhood experiences. This is really important and exciting to me because what's really important in violence prevention, I think in public health in general, is to think about what we can create. What do we have to create to address these things. When you approach a community and talk to them, hey, we need to reduce your youth violence rate, they don't generally respond to that very positively. But if you talk to them about what you want to create, that's where positive experiences, um, protective risk behaviors really come into play. In child maltreatment, we have a mantra: it's safe, stable, nurturing relationships and environments. That's what we're trying to create: safe, stable, nurturing relationships and environments. So positive experiences are a lot about connecting this to school, to parents, to your friends, things of this nature. And in this slide, this one study done I think they use, again, behavioral risk factor surveillance data from Wisconsin. On the left-hand side, you can see the prevalence of depression, adult depression, among those, let's see, let me say this again. And the blue line on the bottom is the prevalence of adult depression among those with no ACEs, arrayed by how many positive childhood experiences they had. And you can see for those with no ACEs, it really doesn't seem to have much of an effect. But if you go up the line, you can see, let's go to the top one. For those with 4 to 8 ACEs, the prevalence of adult depression with just 0 to 2 positive childhood experiences was almost 60%, whereas the prevalence of adult depression among those with 4 to 8 adverse childhood experiences was about 21%. So positive experiences seem to mitigate the impacts of adverse experiences. So again, going back to my point, to the extent that we can create these positive experiences for children, we can mitigate the effects of adversity to a certain extent, or we hope. This is an area which needs a lot more attention and research, but one I think is potentially very important. I want to end by talking about the opportunity for international work. I really believe that we need to bring together our work domestically and internationally, that there's sort of an artificial divide that's been created. Sometimes it's for political reasons. The funding's different, but we have so much to learn from each other. I think other countries can learn from us, and we can learn a lot from other countries. We've been engaged, and this is work that Lindsay's been very closely involved in over the years, in conducting surveys of violence against children around the world. And we've done about 25 different surveys since about 2007. And you can see many of these surveys are in sub-Saharan Africa. And the reason for that is because a lot of the support we got for these surveys came about from PEPFAR, the President's Emergency Plan for AIDS Release, because they recognize the interconnection between exposure to violence, particularly sexual violence among young girls, and HIV risk behaviors. In almost every one of these studies that we look at in these surveys, we find that those children experiencing violence during childhood, and the more violence they experience, are least likely to use condoms as young adults, are more likely to have multiple sex partners, are more likely to engage in other risk behaviors associated with HIV. So PEPFAR invested heavily in these surveys and has helped us to expand them in many parts of Africa. These are really data to action. It's a data to action approach. We're not just collecting data for research and analysis. We're collecting data to guide these countries in efforts to plan for how they can prevent violence against children. And so we've learned an awful lot, and we are now trying to take what we've learned globally and apply it in Baltimore, Maryland. And we're doing one of these surveys, these facts type surveys in Baltimore, hopefully within the next coming year. So this has been incredibly rewarding work. There's now a global partnership to prevent violence that's really taking up a lot of this work and expanding it in other ways around the world. So there's so much happening in this field, so many opportunities to really make a difference. One of the things we have done internationally, similar to what I talked about earlier, is to develop a compendium of the best available evidence. And this is a compendium that's been endorsed not just by CDC, but by UNICEF, WHO, the World Bank, USAID, and other international agencies, all getting behind trying to get the evidence applied to address the issue of violence against children globally. So that's where the data to action comes in. When we do a survey, we use this compendium to help the countries think about what sort of approaches to prevention should they be applying in their community based on the data, and what can make a difference. Just to show you from one country, this is Kenya, where we've done the survey twice, once in 2010 and once in 2019. After the 2010 survey, Kenya implemented a broad range of policies and programs to address violence against children. And PEPFAR, the President's Emergency Plan for AIDS Relief, also invested in a variety of interventions that applied both to HIV and violence in Kenya. So they invested their funding in this issue. And what we saw was a substantial reductions between 2010 and 2019 in these major categories of violence: physical violence, emotional violence, and sexual violence among children, both for females and males. You can see declines in each one of them, which was amazing to see and so gratifying. Now, we can't be certain that these changes were attributable to the policies and programs that were implemented in Kenya. There may be demographic changes, reductions in poverty perhaps, that also are associated with these changes, but this is very encouraging, and others will go into more depth and detail to try to find out exactly what happened in Kenya, because I think it's very encouraging for what can happen in other countries around the world. I just want to say that we also did this survey in El Salvador and Honduras. And this is again and the importance of this relationship between domestic and international work. They're interconnected. What's happening in Central America impacts the US along our border, for example, and politically, of course. In these surveys, we found some things that I think are probably not surprising, but increased violence locally was associated with increased migration to escape violence. We also documented most external migration in these countries was to the US. The migration process, not surprisingly, increases the vulnerability of children who migrate. And also that there's many parents who migrate and leave their children behind for economic reasons, to get jobs and so forth, and earn money that they can send back to their families. But parental migration, we found, increases the vulnerability of children to violence to stay. So really important research that I think talks to directly about the interconnection between violence globally and domestically. Let me just end with my favorite quote from Jack Shonkoff, really a prominent leader in the whole issue of child development. He said that one of the most powerful ways to change the world is to make it better for kids. And I would add that one of the most powerful ways to make the world better for kids is to reduce their exposure to violence. So thank you very much. With that, let me open it up for questions.
Great. Thank you so much, Dr. Mercy. We really appreciate your time and your expertise here. We will open it up for questions now. I think there might be something here in the chat. Let me see what we have. Yes, from our colleague, Dr. Sean Joe, says, any USA community level demonstration projects that has resulted in substantial or population level reductions greater than 25% for, if yes, how long was the impact sustained?
I wish I could answer that question explicitly, but I will say there are evidence of community-based interventions that reduce violence. We fund these things called youth violence prevention centers across the country, where they're academic community partnerships. One's in Chicago, for example, and in specific communities in Chicago, through a combination of and working with the communities hand in hand, they have found substantial reductions, able to demonstrate substantial reductions using programs and approaches focused on changing individual behavior through social emotional learning approaches, as well as parenting types of approaches, as well as trying to change the environment in certain ways. There is evidence of this. Now, our ability to expand it and build on that evidence is limited, as I've said. But if you look in these compendiums, you can see some specific examples to point to on that score, Sean. A good question. We need more of these examples, though.
Thank you. And Camille, I see you have your hand raised. Would you like to ask your question?
Yeah, sure. First of all, thank you so much. I really enjoyed that talk. And I was just wondering, I guess I had two quick questions. One, I didn't realize that the federal funding freeze had kind of partially de-thawed last year. And I was wondering, like, why now? What caused that? And then also, if you could speak very briefly on, I know the research is still fairly new regarding the pandemic, but that huge spike, what are researchers thinking might have caused that? Is it socioeconomic challenges, mental health challenges, et cetera?
Yeah, good questions. Wow, it's kind of hard to figure out politically what happens in Washington sometimes, but I think what happened was, this is something that people in public health have been pushing for for a long time, trying to get the funding restored to do research on firearm injuries. And I think what happened at the end of the Trump administration, so this is before the Biden administration, right? Which is even more amazing, right? There was a negotiation about the federal budget, and the Democrats were able to get the funding increase incorporated. And because they needed to sign a budget increase, the president signed it. So it got into place. So it's hard to know, but somehow it happened. So I don't want to question it too closely, but why the spike? There's a lot of theories, right? One is there's been a talk about more guns, right? There's been a lot of people buying more guns. So the question is, have more guns contributed to the spike? We're not sure. There were already a lot of guns out there, so marginally, does more make a difference? Another theory is that policing has changed, right? Because right around this time is also a lot of the police shootings that occurred, very well publicized, and this may have altered policing. Not sure about that either. There's also other changes in terms of, as you mentioned, mental health issues, isolation. Although the firearm suicide rate did not increase that much, just a little bit, but it was already at a very high level. So maybe drug-related violence. At the same time, we have pretty dramatic increases in opioid overdose. In the last epidemic we experienced in the 1990s, it was associated with the crack epidemic and the breakdown of the drug distribution networks. I don't think that's something similar has happened now with the distribution of opioids, the illegal distribution, but it may have. These are things people are exploring, but those are some of the ideas that people have.
Thank you. And we have a couple of questions in the chat that are kind of around methodology for ACEs. I'm going to kind of combine these questions into multi-part question. One is about, are there any individual ACEs that are maybe more important or significant in terms of impact on health than others? And then Also, what about the validity and reliability of ACEs scores in other cultural contexts, other countries? Is this something that can be applied elsewhere? Or how do we think about using ACE scores in other cultural contexts?
Yeah, we've been doing, let me answer the second question first and then come back to the first. Both really good questions. There's a lot of work in other cultural contexts, both in Europe and we're in these violence against children surveys I mentioned. We are doing ACE type analyses and we find the same pattern, the same types of patterns. The more that children experience adversity, and you add that up, the more they are likely to have negative health outcomes or engage in risk behaviors. So while we do adapt the questions to the cultural context, there's similar type of questions about exposure, and you find the same thing. It's an amazing thing about this ACE research that you find the same patterns over and over again, very consistently. So yes, they're finding the same thing in other parts of the world. On the first question, it's a really good question. Now remember, the really central thing about ACEs is the accumulation of ACEs. But this is a very important question and something we want to look at more. Which ACEs are more important? And are we not measuring some ACEs, some of the ones that I mentioned, like exposure to violence in the community, that should be ACEs and are maybe more important than some of the ones that have traditionally been measured. This is a very important area for research, and more research needs to be done. Which ACEs are more important, and which, not just among the ones we already collect traditionally, but which ones aren't we measuring that we should be measuring?
Great, yeah, thank you. Before, I see your hand is raised.
Right, I wanted to ask the question to say, in the spirit of counterflow of insight and wisdom from both the global south and the global north, what has been observed from the global south that could be applied here in the US?
Oh, there's a lot, and others on this call maybe answer this better than me. Let's give me one example. It has more to do with intervening in response to violence. But one thing we've learned from the global south is that community health workers can be used to deliver cognitive behavioral therapy to victims of sexual violence in ways that mitigate the consequences of that exposure for mental health, for example. In the United States, it would be interesting to apply this type of approach in the United States, because I don't think in many communities, people exposed to this type of violence are getting any type of intervention. It may be in part because there's limited accessibility to the types of people who can deliver that type of intervention. So that's one example before that comes directly to my mind, but there's others. The other thing I think is, I think we are in the process of learning a lot about delivering interventions in a less expensive way from low-income countries that could potentially be applied in this country, make it more affordable for inner cities and other communities to deliver violence prevention. So that's something I always look for. But that's a great question.
Great, thank you. And I think we have time for a couple more questions. I see a question in the chat about, is there a proposed mitigation plan to protect the ones who are already exposed for high ACE scores? And I think maybe you talked about that a little bit with the technical packages and thinking about maybe tertiary prevention strategies, but maybe you could just talk about that a little bit more as well. Yeah,
the evidence is very strong for different types of interventions to do exactly that. Cognitive behavioral therapies, I'm not an expert in that area, but there are a lot of strong evidence that we can mitigate those consequences. Not sure that, the people exposed to these things are always getting those interventions. So the challenge is, how do we make accessibility to them greater?
Thank you. I actually have a question. I'm going to take this opportunity to ask a question here. Earlier in your talk, you mentioned when you're talking about scaling up evidence for violence prevention, you talked about the political will is not always there to, to expand on the application of knowledge, but you said we're moving in that direction. I'm just wondering if you could, expand on that a little bit, and how do we, with the pendulum swing in political administrations, a lot of times things in public health, we move in one direction and then we move away from it. I was wondering what your thoughts on are how we can avoid that pendulum swing when we move towards, that political will, and then we back out of it.
Yeah, great question. 40 years ago, just to put it in the broadest perspective, 40 years ago, the words violence and prevention were rarely used in the same sentence. So we've come a long way. And I will say during this past year, with the new Congress and new administration, there has been much more attention to a public health approach to these things. But I think, politically, it's always been easier for a politician to stand up for tough law enforcement. They're often perceived as being soft if they advocate for a public health approach to violence as opposed to a law enforcement approach. I believe that where we need to come to is recognizing the value of both approaches, that it shouldn't be either public health or law enforcement, but the integration and working together of those sectors in productive ways. And I'm hoping we can come to that point. We still have a ways to go. It's still challenging for a politician to endorse public health approaches, I think, because of that perception that they believe is out there about being tough on crime is important.
Great. Thank you. And then I think we have time, hopefully, for this last one from Lindsay. She says there is increased evidence for survivors of violence. Can you talk a bit about interventions that have been effective for perpetrators of violence?
Many of the types of interventions in these packages that I mentioned earlier are relevant to perpetration of violence. And I will say, by the way, that I think that's where our main focus should be, on preventing perpetration. It's not that we don't want to address reducing the likelihood of victimization or not emphasize the need for interventions for people who have suffered from violence, for sure. But I think a lot of our effort scientifically should be focused on reducing perpetration. That's the problem, perpetration. There are social emotional programs, school-based approaches that have been shown to have modest approaches in reducing engagement in violent behavior. There are changes in the environment. Greening is one that's become very, that I think we have evidence for, reducing cleaning up vacant lots, creating green spaces, engaging the community in those spaces and changing them in their community is associated with reductions in firearm violence. It's hard to say whether it's perpetration or victimization, but it results in lower perpetration. And again, well, let me leave it at that, but those are some examples of what I think about them. There's a lot of work on perpetration you can see in these compendiums.
Great, thank you so much. I know we're at time, so if everyone can join me in thanking Dr. Mercy one more time for your time and expertise and all the wonderful work that you're doing in violence and injury prevention. And thank you also to Dr. Lindsay Stark for being here and partnering with us on this event. So thank you so much, everyone. Thank you for being here, and we look forward to seeing you all again soon.